This year at ASH, we have a couple of presentations providing update on the master study that, among other things, I think helps provide some information about how the role of autologous transplant is or remain in multiple myeloma in this era where patients are treated with quadruple therapy and the vast majority of patients have a deep response. So in this study, we combine 4 very active drugs: daratumumab, carfilzomib, lenalidomide, and dexamethasone, for a period of induction of, there was 4 cycles, followed by autologous transplant. Patients subsequently could have additional cycles of consolidation, up to 8 cycles. What was unique about this study is that at each phase, induction, post-transplant, and if necessary, post each 4 cycles of consolidations, patient had MRD assessment as done by next generation sequencing using the clonoSEQ platform. And what this trial had some enrichment for high-risk patients and include patients regardless of age. So we had patients all the way to the 79 years old. And what we found, and that's quite important, that is you can do this. You can do MRD response adaptive therapy in a multi-institutional setting. And we found MRD to be informative in over 96% of the patients. Not surprisingly, the responses were quick and deep. Overall, the 80% of the patients achieved MRD negativity to 10 to minus 5, and 66% achieved MRD negativity to 10 to minus 6. And overall, 72% of the patients were able to achieve 2 consecutive reads of MRD less than 10 to minus 5, and transition to a phase that we call MRD sure, where patients do not receive any additional therapy. They're just monitoring. They just receive monitoring, including periodic MRD assessment in the bone marrow. Overall, the cohort did very well. Patients with no or 1 high-risk chromosome abnormality did exquisitely well. The 2-year PFS is 91 and 97% for standard and high risk. And the 2 years overall survival is 96 and 100% for patients with 0 or 1 high-risk abnormality. The problem really remains on the patients that we're now recognized as ultra-high risk. Those are patients with 2 or more high-risk abnormalities, where the PFS of 2 years was only 58%, mostly due to progressions while still on quadruple therapy. So that indicates that this transplant, including platform, is very active and can yield patients to at least some long-lasting period without any therapy in the vast majority of patients. But for those patients who have ultra-high-risk disease, we're still in need of innovation, perhaps with introduction of novel therapy. So that really calls into the question the role of transplant. We have had other series, such as the Manhattan study, also with the KRdD platform. They had very deep responses, including MRD negative responses in over 70% of the patients without the use of transplant. I believe that is a very valid point. And I think in the near future, we should explore for patients who achieve MRD negativity with induction therapy, whether transplant is still necessary. And that is going to be done in at least 2 studies that I'm aware of. Conversely, for a majority of patients who remain MRD positive after induction, even with quadruple therapy, we believe the role of transplant remains essential. And that is very well highlighted in an abstract presented by my colleague, Dr. Susan Ball, using data from MASTER. So she took patients who were still MRD positive after induction therapy, and she was able to measure the impact of autologous transplant by the reduction of MRD burden on a patient-by-patient basis. And What you found was that there was an average a 1 log reduction on disease burden with autologous transplant. But more interesting, that reduction was even of greater magnitude among the patients with high risk and ultra high risk disease. So I think we have to, in general, remains a very important tool. Can yield to more patients achieve MRD negativity. It has been demonstrated in randomized trials to remain essential for long-term disease control, as recently demonstrated in the IFM 2009 trial, and the EMN 02 trial, and on the Forte trial. But I think we have an opportunity in the near future to refine the use of transplant. Perhaps consider omission on a randomized setting among those patients who become MRD negative with quadruple therapy, and perhaps understand a little bit more what are those patients going to have the greater impact on the clone with the use of autologous transplants, so we can deploy that therapy more strategically.